So today we're talking about pulmonary stenosis and pulmonary atresia with intact ventricular septum. These are related, but sometimes or oftentimes behave somewhat differently. So we're talking about severe stenosis of the pulmonary valve, and mostly I'm talking about stenosis that presents as the neonate. So babies generally are blue, or with atresia of the pulmonary valve. So there has to be a patent foramen ovale, otherwise blood can't get out of the right atrium, or at least all of it can't. And there's variable hypoplasia of the right ventricle and tricuspid valve. In pulmonary stenosis, this is usually less. Pulmonary atresia with intact septum, the RV and tricuspid valve tend to be smaller. But the pulmonary arteries are usually pretty close to normal size. The pulmonary trunk may be small, but the branch pulmonary arteries are usually at most mildly hypoplastic and usually pretty close to normal size. The ductus in pulmonary atresia intact septum, of course, is the only source of pulmonary blood flow. And in pulmonary stenosis, it may be an important source of pulmonary blood flow. In pulmonary atresia, we often see coronary artery abnormalities, sinusoids or fistulae between the right ventricle and coronaries, and sometimes stenosis or atresia of part of the coronary artery system. If you were at conference this morning, you heard a bit of a description of this, and also the idea that this is not a static situation necessarily, but can change over time. So here's the pathophysiology. In pulmonary atresia intact septum, there's no antegrade flow across the pulmonary valve. With pulmonary stenosis, there may be a little, but it may be quite reduced. So the right ventricle is very hypertrophied and usually smaller than normal. There's often tricuspid insufficiency because the blood can't go forward, so some of it often goes backward. Sometimes, as we'll see, the tricuspid valve may be a bit dysplastic. The pressure in the right ventricle is almost always suprasystemic. So then the right atrial pressure is a bit elevated because there's really no place for blood to go. And so we see right to left shunting across the atrial septum, and that's why patients with this are blue. Pulmonary blood flow may completely or partially depend on retrograde flow across the ductus arteriosus back into the pulmonary artery. And the desaturation that we see, arterial desaturation, is because of the right to left atrial level shunt. So that's basically the pathophysiology here. So these babies are blue from birth. If the pulmonary stenosis is rather mild, then they of course have normal saturations. And they usually have a murmur from the first day of life with pulmonary stenosis and no congestive symptoms. So again, there's variable cyanosis, a forceful RV impulse in pulmonary stenosis, usually because of the right ventricular hypertrophy. Some cases of pulmonary stenosis, the right ventricle is pretty small, and so you may not find this very much. There is a variable ejection click. The pulmonary valve makes noise when it opens. And the second heart sound is usually normal, although if the pulmonary valve is dysplastic, it may be single. You may not hear the pulmonary component. Now, the reason that the ejection click is variable here is because of variation, again, in filling of the right heart and filling pressure of the right heart, and the usually very low pressure in the pulmonary artery. So in severe pulmonary stenosis, again, the pressure in the pulmonary artery is low. This is after the ductus is small or closed. And the diastolic pressure in the right ventricle during inspiration, for example, when you're maximally filling the right ventricle, the diastolic pressure may well approach the pulmonary artery diastolic pressure. And so the valve begins to open a little bit during inspiration. And so it has a short excursion because it's starting to open now from a partially opened position. And that reduces the intensity of its opening sound. So during inspiration, the click tends to go away or become softer, whereas during expiration, it becomes accentuated. And that's just because of the variations in filling of the right heart that we've talked about before, like with atrial septal defects. So that's why you get a variable ejection click here. And that can help you distinguish this from, say, an aortic murmur, which in very small babies, the chest is so small it can be hard to localize murmurs. So the variable intensity of the ejection click can be very helpful in realizing that this is pulmonary stenosis. And then, of course, there's a systolic ejection murmur at the left upper sternal border that usually radiates to the suprasternal notch and often to the apex for some reason. And there's variable hepatomegaly, depending on whether the atrial septum, if it's obstructed, for example, there you may see a big liver and even ascites, or if there's other evidence of right heart failure. Usually that doesn't happen in neonates, but it may happen in older patients. Pulses tend to be normal in this. The EKG shows right heart dominance, right ventricular hypertrophy, often right atrial abnormality as well. And the chest X-ray usually shows normal or decreased pulmonary blood flow and a normal heart size. So here's an example of pulmonary stenosis. Here you can see the pulmonary valve doming up here, and there's antegrade flow and a little bit of regurgitation. But you see how the leaflets don't move apart. There's just a central orifice here. This is not terribly severe pulmonary stenosis, but you can see the valve is quite abnormal appearing, and the motion of the valve is quite abnormal. Here's a little closer up. You can see the leaflets don't separate because of commissural fusion. So you see this domes up, it forms a little hat-like structure or dome-like structure. And there's usually right ventricular hypertrophy. Here, we're measuring a gradient here that's somewhere in the 50 to 60 millimeter of mercury range. And of course, we're seeing right to left shunting here at atrial level. Here you can see the blue flow going across the foramen, producing some cyanosis and allowing pop-off from the right atrium because of reduced filling of the right ventricle because of the pulmonary stenosis. This is flow through the ductus, which is often a major source of pulmonary blood flow in patients with pulmonary stenosis or pulmonary atresia intact septum. And here's another example. This is more severe stenosis. Here you see this is a very hypertrophied and relatively small right ventricle. Here's tricuspid inflow here. It's not so bad, but the right ventricle itself is pretty small. And here you can see there's just a tiny central jet. And when we look at specimens in a few minutes, you'll see that there's often fusion of all the commissures and just a little central orifice in the middle of the valve. And that's basically what we're seeing here, just this little squirt of blood going across the valve during systole. So this is quite severe pulmonary stenosis. And you can see over here, this is a small right ventricle. You see how it doesn't even go quite halfway down toward the apex here. And the tricuspid valve is small, quite a bit smaller than the mitral valve. So this is an extreme form of pulmonary stenosis. Usually the right ventricle tends to be more normal size, but sometimes we see this amount of hypoplasia. So what do we do for this? By far the most common treatment for this nowadays is balloon dilation, and this is usually quite successful. In some cases, we do surgical valvotomies, particularly in patients who have a very dysplastic pulmonary valve. Sometimes patients with, for example, Noonan syndrome may have a very abnormal, very thickened valve. And so balloon dilation or even using a cutting balloon or something like that may not be adequate, and the annulus may be small in these valves as well. And so a surgical valvotomy, sometimes with enlargement of the valve annulus, is necessary. And sometimes, particularly in patients like this, where there's really a small right ventricle, a systemic to pulmonary shunt may be necessary, either stenting the ductus or creating, for example, a modified Blalock-Taussig shunt. These are older data, but I think they're still pretty correct in that there is close to 90% freedom from reintervention out quite some time after the balloon dilation. What we're seeing now is the incidence of pulmonary insufficiency becoming important in these patients, like we see in patients with tetralogy of Fallot. So here you can see two groups of patients, one that underwent balloon dilation and then another group that underwent surgery. And you can see follow-up here out to, in this case, about 25 months here. I'm sorry, years, I said months, it's years, 25 years, and here 50 years of follow-up. Now, at first glance, you might think that this looks quite a bit better than the surgical group, but remember, in the surgical group, 25 years is here. So it looks really pretty similar. Here, the freedom from reintervention is something like 80% at 20 to 25 years. And over here with surgery, it's maybe 85% at 20 to 25 years. So probably not significantly different. And then you begin to see reinterventions in the surgical group, but we haven't been able to follow the balloon dilation group in any numbers more than about 20 or 25 years. So we don't have the same kind of numbers that we have here in the surgical group in this second part of the surgical group. And that's where we begin to see the effects of pulmonary insufficiency, just like we do in tetralogy of Fallot. That's about the age group where most patients begin to present for the need for pulmonary valve. And the same thing is happening in patients who've had either a surgical valvotomy because their valves leak as well. Dr. Natus used to tell us as fellows that if a patient with pulmonary stenosis came back from the operating room without a pulmonary insufficiency murmur, then he didn't have an adequate valvotomy. And that's probably true, and it's probably also true for balloon dilation. Now, we haven't seen that phase of the balloon dilation population, and maybe we won't. Maybe the results here will continue to flatten out instead of having this drop-off like we see in the surgical group, but we won't know that for a few more years. This is just another series, a different series, a European series, looking at patients with pulmonary stenosis and balloon dilation. Most of these patients had more than 10 years of follow-up. 60% of them had moderate to severe pulmonary regurgitation. So 60% of those with more than 10 years follow-up had significant pulmonary regurgitation. And the one risk factor that this group identified was a small baby, small body surface area at the time of the balloon dilation. So here you can see, again, at about 20 years, we start to see a drop off here and the reintervention rate increases because of pulmonary insufficiency. You can see mild valvar pulmonary stenosis with just a little doming of the valve like you see here, but good leaflet separation. And here you can see the valve looks almost like there looks like there are 3 leaflets, but the commissures are a little bit fused and don't open completely. So this is a very mild valvar pulmonary stenosis. The indications for intervention, certainly if there's a right to left atrial shunt, we intervene in these babies. A peak gradient more than maybe 25 or 30 millimeters of mercury would probably buy a balloon dilation, and certainly evidence of right ventricular hypertrophy would be an indication for valvotomy. Now, pulmonary atresia intact septum tends to be on the more severe end of pulmonary stenosis. These babies, of course, are always cyanotic from birth, and they're always ductus dependent because there's no antegrade flow from the right ventricle. There may not be a significant murmur in these babies because there's no antegrade flow. There may be a tricuspid insufficiency murmur, depending on whether there is tricuspid insufficiency or not. And they can present with extreme cyanosis and collapse if the ductus starts to constrict, if the diagnosis is not made either prenatally or expeditiously in the neonatal period. So they're cyanotic. They have a normal precordial activity because the right ventricle tends to be pretty small. Second heart sound is single. There's no ejection click, usually because the pulmonary valve isn't opening. And there either is no murmur or sometimes a continuous murmur from the ductus at the left upper sternal border. And there may be a holosystolic murmur at the left lower sternal border from tricuspid insufficiency. And this here, the tricuspid insufficiency is a high pressure tricuspid insufficiency. So it's a higher pitched, more blowing kind of murmur than what we usually associate with tricuspid insufficiency in patients, not patients with a systemic right ventricle, but otherwise, where it tends to be a lower pitched murmur and not sounding a lot like mitral insufficiency, which is what this often sounds like. Again, variable hepatomegaly, in part depending on the status of the atrial septum, normal pulses in these patients. Here, there often isn't that much RVH because there isn't that much of an RV, but there usually is right atrial abnormality. So, and there may be decreased RV forces in the axis, unlike most newborns, which is usually over in the 100, 120, 140 range. The axis here may be over in the left lower quadrant, somewhere around plus 45 to 90 degrees. So a little bit, not as much right axis as you expect for a newborn. And again, because of right ventricular size. Chest X-ray, there may be normal heart size and normal or decreased pulmonary blood flow. So here's what these patients look like. This is a small right ventricle. You can see right here, there's the pulmonary valve up here. It's moving. There is a valve usually, as we'll see, but there's only retrograde flow from the ductus. There's no antegrade flow going across the pulmonary valve. Here's the left ventricle, and here you can see this very diminutive right ventricle. Here you see it in an apical view. There is antegrade tricuspid flow. You see the red jet when we get into the plane of the tricuspid valve, but there's no antegrade flow across the pulmonary valve. Here's our arch with a tortuous ductus. This is typical for pulmonary atresia to have a sort of an S-shaped or siphon-shaped ductus, tortuous like this, with flow from the aorta through the ductus back into the pulmonary artery. And here you can see some abnormal connections between this small right ventricle and the coronary arteries. There's to and fro flow, antegrade flow during ventricular systole, retrograde flow back into the ventricle during diastole. And we typically see that in patients with very small right ventricles like this. Now here's a bigger ventricle. This one makes it, at least the real cavity halfway down. And then there are these little sinusoidal or interstitial spaces here between muscle bundles that extend down toward the apex. Here, there's a reasonable sized tricuspid valve, but look at it, it's doming. It has mostly attachments to this anterolateral papillary muscle here. So it's almost like a parachute kind of valve, and we see this kind of deformity sometimes in pulmonary atresia and tech septum. But you can see how much bigger this right ventricle is. And again, we see sort of a plate-like pulmonary valve up here. And there, we're back to the long axis view. And here's one with a good sized right ventricle. This is nearly normal size right ventricle. You can see it's very hypertrophied. The function is reduced because there's no place for it to eject blood. So here you can see there's suprasystemic pressure. The septum is bowing back into the left ventricle. There's a good sized tricuspid valve, although it's smaller than the mitral valve. The right ventricle is hypertrophied and doesn't work very well. There's right to left atrial shunting, and here you can see the tricuspid annulus. In this case, it's roughly the same size as the mitral annulus. And there's some tricuspid insufficiency. We often see tricuspid insufficiency. And here you see this sort of plate-like pulmonary valve up here. It's just a disc sitting in the annulus, and there's retrograde flow again from the ductus, which is supplying all of the pulmonary blood flow. And you can see the branch pulmonary arteries are quite good size typically in this condition. Sometimes we don't really have much of an outflow. There's just this little inflow of the ventricle down here. This one happens to have almost like a aneurysm of the basal septum here for some reason. This is the tricuspid inflow right here. This is the tricuspid valve. Here you can see the foramen going right to left. This is all there is of the right ventricle. There's really no outflow up here, nothing going to a pulmonary valve. So occasionally we see that. Usually we don't. Usually there is an outflow. And here you can see abnormal flow in a coronary artery. That's the right coronary right here. And there's to and fro flow in the coronary because flow comes into it through the fistula during systole from the right ventricle and then goes back in through the fistula during diastole. So this kind of abnormal coronary flow is an indicator of coronary fistulas and maybe an indicator of coronary stenosis. We think this happens because as you remember when we talked about cardiac development, the coronaries develop in a couple of phases. The outer part of the ventricular free walls develops from the epicardial system, actually sprouts out from the sinus venosus and then grows around to cover the outer part of the wall. Whereas the inner part of the heart, the interventricular septum and the inner half or so of the free walls of the ventricles, the coronaries here come from endothelial cells, endocardial cells that have become trapped as compaction occurs, as the trabeculae get compressed together, and they become hypoxic and develop into endothelial cells and develop the inner coronary network. And we think that these trabeculae, which are becoming compacted, continue when there's high pressure in the ventricle, in this case the right, but we can also see this in hypoplastic left heart syndrome with a hypertensive left ventricle. Then these fistulous connections probably develop from the interstitial spaces, the intertrabecular spaces that continue to communicate with the developing coronary system in here. At least that's the theory. We're not sure about that, but what we do know is that because of this to and fro flow, high velocity flow out of the ventricle, we see areas of coronary abnormality. We see intimal thickening, proliferation, and eventually these can actually become areas of atresia or stenosis. And you can lose connection between the aorta and part of the coronary system, and this part becomes dependent on flow from the right ventricle for coronary circulation. And depending on how much of this there is, we can consider this right ventricular dependent coronary circulation. There are not really good criteria for deciding how much. Some people have said at least stenosis and fistulas to at least 2 vessels, and maybe that's a reasonable thing. But here you can see this on angiography. Injecting into the right ventricle lights up coronaries all over the place in this case. And here you can see injecting in the aorta, we see the right, but we don't see the left very well, but here you can see the left after we inject in the right ventricle. And there's a clear relationship between the size of the right ventricle and tricuspid valve and the presence of fistulas or coronary stenoses or atresia. The bigger the ventricle, the less likely it is that we'll see fistulae or stenosis of the coronary. These are the ones up here with dots are no fistulae. The little squares are just fistulae only, connections, small ones usually with the coronaries, but no stenosis. And then the yellow are fistulous connections with coronary stenoses, and these are with multiple coronary artery stenoses, right ventricular dependent coronary circulation. And you can see how there is a relationship here between the size of the right heart structures and the coronary abnormalities, the severity of the coronary abnormalities. So the coronary artery anatomy is one of the main determinants of how we treat these patients. If there is adequate coronary artery anatomy, in other words, not right ventricular dependent coronary circulation, however you want to define that, then very often there is either a surgical or a balloon right ventricular outflow tract plasty to open the valve, usually with either a shunt or stenting of the ductus or prostaglandins for some time. And then at some point later, once it looks like the shunt is not necessary anymore, or the ductus, test occlusion of this, and then device closure, and then test occlusion of the atrial septal defect as the right ventricle grows, and maybe device closure. Sometimes these patients need a tricuspid valvoplasty because of either stenosis or regurgitation or both. If, on the other hand, there is right ventricular dependent coronary circulation, then these patients usually get a shunt and then get staged toward a Fontan operation. And we have often considered these patients probably candidates for heart transplantation because of the ongoing risk for ischemia and arrhythmia because of the coronary abnormalities. So here's what happens when you do the radiofrequency perforation and dilation of these. These were 23 patients who were considered to be pretty ideal candidates for this. They had a pulmonary valve Z-score that was not so bad, tricuspid valve Z-score not so bad. And if you look at in this report, this was from 2014, 3.9-year follow-up, 95% of them had a biventricular repair and saturations were more than 92%, but you can see that only half of them by 2 years had not had another right ventricular outflow tract procedure, often surgical procedure. And here's another paper. This is from around the same time. This looked at 50 patients that were divided between surgical perforation and radiofrequency valvoplasty. These were not randomized. These were selected because they were thought to be good candidates for radiofrequency ablation, radiofrequency perforation. And you can see over here of the 50 that underwent surgical procedures, 7 of them went on to single ventricles. So these were clearly included most of the disadvantageous patients. 9 of them had an intermediate procedure, a so-called 1.5 ventricle repair. And 8 of them had a biventricular repair. So clearly these were less than ideal candidates. Over here, nobody had a single ventricle repair. 5 of them had an intermediate or a 1.5 ventricle, and 21 had biventricular repair. So clearly this is the better group from severity point of view. But if you look here, of the 26 who went down this pathway, 16 underwent surgery before they left the hospital, 62%. Whereas 10 of the 26 did not undergo surgery, at least before they left the hospital. And then 7 of the 10, so 7 out of 26 ended up with no surgery long-term, and 3 of these underwent later surgical intervention. So only 7 out of the 26 ended up with no other procedure being needed after a radiofrequency valve perforation. This just shows you the change in outcomes with this disease. When I started in this business in the 70s, you can see that the outcome here was really quite poor. The 6-month survival was only about 40% in these patients. And then it got a little better in the late 70s, early 80s. We were beginning to realize at this point about the coronary artery problems. This is about when those data came about. And then once we realized that and stopped trying to decompress patients with bad coronary circulation, you can see here in the late 80s, by the late 80s, the outcomes had improved really quite a bit. And they've improved quite a bit since then as well. These are just data looking at growth of the tricuspid valve, growth of the right ventricle, and there clear evidence that both of these structures grow in these patients. So patients, even many of those with a very small right ventricle, may eventually become 2-ventricle outcome candidates. So here's an example of early post-outflowplasty. This was a surgical outflowplasty. Here you can see this very hypertrophied right ventricle. There's the outflow patch up here, there. And you can see that there's not a lot of antegrade flow into this patient. It's a pretty small right heart. There's very little antegrade flow. You can see the valve doesn't open very well. And there's a little bit of mid-cavity obstruction here, a little bit of tricuspid insufficiency. And this patient had a shunt, so there was mostly continuous flow with some retrograde flow from the pulmonary artery back into the right ventricle. So this was early post-op. This is late. Now here's the atrial septum. This was 6 months later, same patient. And here you can see the right ventricle has increased in size. The function has gotten a little bit better. Now there's clear antegrade flow out the pulmonary artery, which there was very little before. There's still right to left shunting at atrial level. So this right ventricle still isn't adequate for the entire cardiac output. And the tricuspid valve opens a lot better. It's still quite small. The right ventricle is still quite small. Eventually, this patient underwent a 1.5 ventricle repair. And again, you can see good sized branch pulmonary arteries. This is where the shunt was still present, and this patient was a Blaylock shunt. But you can see changes in the right ventricles in these patients over time. This is a newborn exam. This is the same patient late after outflow tractplasty. This was probably a 1.5 or 2 years later. So again, this was a Congenital Heart Surgeon Society, I think, either that or STS data. 106 out of 271 potential participants, only about 40% of them actually agreed to participate. This was all voluntary data collection. And you can see most of them had a biventricular repair, although a quarter had a univentricular repair and 12% had 1.5. And then there were a couple that hadn't gotten to the final stage of things yet. So outcomes have improved pretty dramatically. Patients with significant coronary abnormalities seem to be at risk for late sudden death and may be better off with transplantation in these patients. So that's what I want to tell you. We'll look at some specimens. Is there a question here? Let's see. Oops. I wanted to get to chat. Was there a question in chat? No, it doesn't look like it, huh? Anybody have a question or?
I guess one thing about the coronaries,
Yeah.
like with osteal stenosis versus you know, a stenosis that's later on in the coronaries, does that make a big difference in thinking about sort of your surgical decision with transplant versus you know, going down a single ventricle pathway?
Yeah, I think it probably does. We see some patients who completely have lost their connection of the coronary with the aorta. So there's osteal atresia, and I think those patients are particularly poor candidates for anything but transplant. But certainly for an initial procedure, yeah, that would, I think, would be pretty definitive for not wanting to decompress the right ventricle if you saw that in a newborn.
That makes sense.
Any other questions or comments? Okay, well, let's look at a few specimens here. You guys can see the blue towel, correct?
Yeah, we can.
Okay, good. Just checking. Oh, can you put the, yeah, thanks. So this is a little heart, a neonate, who died of other reasons, but had just a bicuspid pulmonary valve. And here you can see that. And there's a little nodule right there on one of the leaflets, but you can see this, there are just two commissures here. There should have been probably another commissure over here, but we don't see it. But this patient had essentially no grate across this, just an abnormal looking pulmonary valve. So just to show you a bicuspid valve, and here again, you see there are quite good branch pulmonary arteries out here, and there is a little ductus still, because this was a neonate who died from other genetic issues. Here's a little heart, again, a neonatal heart. And this, I think, really shows you the morphology of many of these very abnormal pulmonary valves. This is our left ventricle over here. Here's the right, which is small. You can see it only comes down about halfway. You can see here's the anterior descending. Normally, we would see the anterior descending out here, but it's moved way over because of the foreshortening of this ventricle. And again, you see the tricuspid valve here. There's a big right atrium. There's an atrial septal defect, actually multiply fenestrated septum primum there that you can see. And the infundibulum gets pretty small as we get up toward the pulmonary valve there. And if we look at this valve from above, you see that it's just a little tiny hole right there in the center of the valve. Okay, that's as zoomed in as we can get here. But here you can see there's one raphe right there. You see that little line. That should have been a commissure. There's another one right there. You can see that little line over there that should have been a commissure. And a third one right here. So this is an acommissural valve. Many of these pulmonary valves are like this. They're just solid leaflet all the way around, except for this tiny little hole right here in the middle. It's sort of like a little volcano. There's just a tiny squirt of blood coming out across this. And the branch pulmonary arteries, again, are pretty normal. There's a ductus here that was the source of most of the pulmonary blood flow in this patient, because you can imagine that not very much blood is going to go across this tiny little hole here in the apex of this valve. So this is quite severe valvar pulmonary stenosis. That's typically what these valves look like. Here's another example. Here's our right ventricle here. It's hypertrophied. You can see how thick that is. Here's the left ventricle over here. You see that the right ventricle is even thicker probably than the left. So there was probably suprasystemic pressure. And here we're looking up toward the pulmonary valve there. And you can see it's quite fused together. And here is the valve from above. These are the branch pulmonary arteries up here. And now, again, you see just this tiny little opening right there in the valve. That's all there is. There's a raphe here, there's one here, and there's one here. So again, an acommissural pulmonary valve, but this is a little bit older patient, and you can see there's just this tiny little opening. This is a 1.5 millimeter probe, and it's about the size of the opening in this valve. This was a year or two old patient who died. This was many years ago. This was in it was 1953. This was almost a 2-year-old patient. But you can see the typical appearance of these valves. And again, the marked hypertrophy here in the right ventricle. And this one was a teenage girl who had severe valvar pulmonary stenosis and survived into her teen years with it. Here's her atrial septum, which is essentially intact. There's no foramen here, it's sealed. There's the coronary sinus down here. Here's her right ventricle, which is just massive and massively hypertrophied. See, the left ventricle back here is quite a bit thinner than her right ventricle. There's some thickening of the tricuspid valve, almost surely from tricuspid insufficiency. And then here is her pulmonary outflow up here. I can get to it here. There's her aortic valve on the other side, just for comparison. Here's the pulmonary valve right here. And she had one of these acommissural valves as well, but you can see that it's actually torn here. Here's the hole in the middle of it, and you can see that this has been torn down into this commissure and over into this, or into this raphe and into this raphe, and here's the other one that didn't have anything done to it. And you can see she has a suture here, a purse string suture that was put into her right ventricular outflow tract just below the valve. She had what was called a Brock procedure. Mr. Brock, who was a surgeon in London, invented this procedure. Basically, you'd put a purse string in the right ventricular outflow tract, put an instrument like a hemostat in through the purse string, push it up through the pulmonary valve, open the hemostat, and pull it back. And this was done, of course, off of bypass. This didn't require bypass, and opened the pulmonary valve. So that was a Brock procedure, and she had that. Unfortunately, she didn't survive it, but probably because she already was quite ill from this extreme pulmonary stenosis, extreme right ventricular hypertrophy. And the fact that she had an intact atrial septum, probably this right ventricle just wasn't able to function, and she couldn't shunt right to left. Here's a patient who also had a surgical valvotomy, and here's the pulmonary valve. You can see there's quite thick right ventricle here. It's about the same as the left ventricle on the other side. The right ventricle is a little bit small. The apex doesn't go quite to the apex of the heart. And here is her pulmonary valve. You can see these are where the raphes were. These are very thick dysplastic leaflets. And she had a surgical valvotomy. Here's the pulmonary arteriotomy up here, not this was post-mortem, but this little blue or little black sutures here was where a pulmonary artery incision had been made. And this basically, again, was done from above with an instrument through here and just tearing the leaflets. And you can see the very thick dysplastic nature of this valve. Even after this, I suspect she probably still had some pulmonary stenosis and probably developed pulmonary insufficiency and had a small non-compliant right ventricle. Now, nowadays what would happen is a balloon dilation, and this is a patient who had a balloon dilation. Again, you see marked right ventricular hypertrophy, some tricuspid valve thickening of the leaflets. Here's the left ventricle. You can see the right ventricle is at least as thick as the left, probably thicker. And there may be a little endocardial fibrosis there. But if we look up here at the valve itself, this patient had, as I say, a balloon dilation. Again, you see this tearing often into commissures or into raphes. Over here, there's a raphe, and you can see the leaflet tore just adjacent to it. The same thing here tore into this raphe. This one stayed intact. It's a little bit thicker, and so probably was less likely to tear. So this was a balloon dilation in this patient, producing that appearance to the valve. So it's not surprising that they would have some pulmonary insufficiency. And here's another one that had a balloon dilation. And again, you can see where the raphes were in this case. And the balloon has torn largely into the areas of the raphes here and over here, maybe a little bit there, but that's still pretty thick. But you see, this is a very dysplastic, thick valve. So even with this, you can imagine that there would still be some pulmonary stenosis in a small right ventricle, small outflow tract up there, marked hypertrophy, so undoubtedly poor filling characteristics, and a smaller than usual tricuspid valve as well. So that's pulmonary stenosis. Let's talk a little bit about pulmonary atresia intact septum. And here is fairly typical pulmonary atresia intact septum heart. You can see here's our right atrium. There's atrial communication there that's good size. Here's coronary sinus down here. There's the ASD up there. And here's our big right atrium. It's pretty dilated. And then here's a small right ventricle. And again, you see where the anterior descending is here. It's right in the middle of the anterior wall. Usually it would be over here. And so that indicates right ventricular hypoplasia. It's shortened in an apex to base dimension. And here you can see the outflow. It's pretty good size outflow up here, good size branch pulmonary arteries and even the pulmonary trunk. And this is what I mean by a plate-like pulmonary valve. Look at this valve. It's like a little plate. sitting here in the outflow tract. This was opened post-mortem. Otherwise, this was closed to here. And you can see there's a raphe here, and one here. The difference is that there's just no opening in the apex of this valve. There's no little hole out here, so there was no antegrade flow. Sometimes these valves can move up and down with systole, and you may see that on echo, but without any antegrade flow. But this is the kind of valve that we often see in pulmonary atresia and intact septum, and this is the kind of valve that's probably a reasonable candidate for a radiofrequency perforation and balloon dilation, or some other kind of perforation, however you choose to do it. You can see what it looks like from below there. The infundibulum is a bit small. And again, the branch pulmonary arteries here are quite good. Here's the right, left, and then there was a ductus up there. So good sized pulmonary artery. So that's a nice example of what the valve looks like. Sometimes we see a right ventricle like this where there really isn't an outflow. You can see people were looking for an outflow here, but this is all just dissected muscle up here. There's really nothing going up, just the inflow part of this ventricle, and maybe a little bit of trabecular apex down here. These are those intertrabecular spaces that sometimes you see on an angiogram. You'll see just a little lines of contrast coming down here in between big muscle bundles. And this is what that really looks like. The tricuspid valve here is quite small. And if we look from above, here there's left ventricle, left atrial appendage. Here's our aorta, which looks normal. And here's the pulmonary trunk, which is somewhat hypoplastic. The branches are good size. Here's the right, there's the left. And if we look at this valve, again, you see this plate-like valve with the 3 raphes there, but it doesn't open at all. And there's really nothing under it. There's no cavity down there. It's just muscle. It's just been dissected up into the muscle. So there's really no outflow in this particular example. And that's unusual. Usually we can see an outflow, but occasionally it looks more like that. And here's another one with a pretty good sized right ventricle. You can see this goes almost all the way to the apex here. The tricuspid valve is again very dysplastic. You see these cords are short and scarred down, retracting this leaflet, tethering it to the septum, so there was a big regurgitant orifice here. This patient had a lot of regurgitation in a very large right atrium here. This patient had surgery and had partial closure of the atrial septum, and then had an outflow tract-plasty done. You can see there's the outflow going up that way, and here's a patch, pericardial patch here that was put into the outflow, and you can see back down. There's some remnants of the pulmonary valve up here, and this is back down toward the ventricle. So this was a typical surgical outflowplasty, again, to good size branch pulmonary arteries. But again, you see this very dysplastic, thick valve remaining leaflets here. Most of the leaflets have been removed. So those are some examples of the variation in size of the right ventricle that we can see. And now I want to show you some of the coronary abnormalities that we see. So here is, here's our aorta over here. This was the pulmonary trunk, and you can see the pulmonary valve is closed. This is pulmonary atresia intact septum. There's a very small right ventricle here, and there are these intertrabecular or sinusoidal spaces. There's a little outflow going up this way. Very small tricuspid valve. If we look at this from the atrial side, here's our right atrium. There you can see the orifice of this tricuspid valve is quite small. There's the mitral valve on the other side. And there's some, it's like prolapse of the mitral valve. But you see the difference in size. And so here's our left coronary right here. Here's the pulmonary trunk. Here's aorta. So this is coming out behind the pulmonary trunk. Here's the main left. And then it bifurcates into a circumflex here and an anterior descending. Now, if we follow the anterior descending, you can see that it comes to here and stops. there's an area of atresia right here in the anterior descending coronary. And then this is the more distal part of that anterior descending after the little atretic portion there. And if we follow it, it connects with one of these sinusoids in the right ventricle. Here you can see the coronary right there coming right into this little sinusoid right there in the ventricle. And then further down here, this is the more distal anterior descending coronary now. It's coming out of the right ventricle and supplying the apex of this heart from the right ventricle. And there is also an abnormal connection right here. Here's the right coronary coming down. And here you can see it sort of V's over here like that. And that's a fistulous connection with the inferior part of this little right ventricle. So there are two coronaries are involved here with fistulous connections, and one of them has an atretic segment. The anterior descending here has an atretic segment there. So this is the extreme form of the coronary abnormalities that we see. And you can see there's some scar over here in the left ventricle. You can see in various places here from ischemic change. Here's another example of a coronary abnormality. This was an older patient who, this was known, and this patient had had a Fontan operation and then started having life-threatening arrhythmias and ended up getting a transplant. So here's our aortic root, and here's the right coronary over here, which is really pretty normal. And here, so this is the right coronary sinus. This is the non-coronary sinus, and here's the left coronary sinus over here. And you can see this was the ostium of this left coronary, this huge thing. And if we look at it from the outside, you can see here's the sinus with the ostium, and then immediately the coronary cones down and becomes quite small. And look how thick the walls of this coronary are. This is very abnormal. This is fibrointimal hyperplasia, proliferation here. There's a lot of ground substance. There are cells in there. You can see how this causes severe stenosis of this coronary. This is the circumflex over there. And then this is the anterior descending. This is the left main, but you see how abnormal. Look at the thickening here and fat deposition in this that you can see there. And then the coronary becomes quite large as we come down. There's a perforator coming out of it. And then if we follow this along, it just ends up in the right ventricle. So this is a big fistulous connection between this anterior descending coronary and the right ventricle. It just sort of ends there. We can't follow it any place else. And so here's our right ventricle. This is the base there. There's tricuspid valve back here. And these are some of the trabeculae. You can see how thick this ventricle is because it was never decompressed. And here's the next slice. You can see, again, intertrabecular spaces there with massive hypertrophy. And if we continue to follow this down, here's the left ventricle over here. This is right. This is septum here in the middle. And you follow this down like this, and the cavity gets smaller and smaller. And eventually, we end up with just a bit of a dilated vessel here, which ends up as the distal anterior descending coronary that comes out of this right ventricle. So this was all supplied by the right ventricle. So you can see the coronary anomalies that we see. And this was a patient who had lost the connection between the left coronary and the aorta. So here's our aorta over here. Here's the left coronary. That's the circumflex going back there. This is the anterior descending as far as it goes here, but there's no connection here between this coronary and the aorta. So there's, it's lost the connection. Its only connection is here, this fistulous connection with this little tiny right ventricle here. It's almost like the right ventricular outflow tract is the left coronary in this case. You can see how tiny and muscular this coronary is. And now look in the left ventricle here. Look at these papillary muscles. You see this yellow material around here? That's dystrophic calcification from ischemia, infarction, and then calcification of basically dead tissue. So you can see these papillary muscles are all infarcted and calcified, and this patient, of course, underwent transplantation because this had produced a severe ischemic cardiomyopathy. So that's some of the coronary abnormalities. I'll just show you a couple of examples of outflow tract plasty. This patient actually had a homograph put in the aortic position. It was not a valved homograph, but a homograph put in here in the pulmonary position, sorry, as the outflow tract in this case. And again, you can see how this can become like a parachute valve. You can see how everything sort of cones down on this big anterior papillary muscle here, and that's the orifice of the valve there. It can be a bit like a parachute valve. But this is a patient who's had an outflow tract plasty. And the last one is just another outflow tract plasty, again, using homograph material here as the patch and going down into the ventricle. There's another one of these valves. This was a postmortem cut in the valve right here. This leaflet was solid before postmortem. So you can see how this all cones down to a single papillary muscle here and can act like a parachute tricuspid valve. And you see there's marked hypertrophy. There's a very small outflow tract here up to the valve, and then patching of the outflow probably didn't quite get proximal enough. So this patient probably still had some significant outflow tract obstruction. So those are pulmonary stenosis, pulmonary atresia, intact septum. Any questions about anything? Some of the coronary anomalies that we see. And okay, just a reminder again that we won't have a conference next week, so make sure that your friends know, and that's on the schedule, that we won't be here next week, but just be sure that everybody knows that. So have a nice Thanksgiving, and we'll see you guys later.
You too. Thanks, Dr. Sanders.
Okay, bye-bye. Here's recording.